The next paper is Learning Curve for Laparoscopic Choledochal Cysts Excision, presented by C1 from Guangzhou Women and Children Medical Center.
Good morning. I'm Wenjie from Guangzhou Women and Children's Medical Center. Thanks for giving me the opportunity to present here. Nothing to disclose. As you all know, learning curve is an important method to describe the nature of procedure, to guide the initiation of a new surgical procedure, and to train the young surgeons. There are many learning curves that has been studied in many minimal invasive procedures, but that of the laparoscopic choledochal cysts excision has not been reported yet. From November 2010 to September 2014, 92 patients of choledochal cysts underwent laparoscopic cyst excision in our hospital. All the procedures were performed by the same surgeon. And the foresight technique was used to complete the procedure. Of the total patients, the average operation time was 283 minutes from 156 to 540 minutes. And 60 cases converted to open. Postoperative complications occurred in 6 patients. This is the causes of the laparoscopic conversion. 6 was because of the severe adhesion, and the others include the biolimb or rose-wide twistage, common hepatic duct stenosis, and accessory hepatic duct injury. And the complications with was 6, including the bile leakage, pancreatic leakage, chalk site hemorrhage, umbilical incision liquefaction, wound dehiscence, and killer's abdomen. This is the learning curve. The length of the operation and the calculative sum of the procedure presented a statistically significant logarithmic relationship. And the learning curve consisted of 2 stages, the rising period and the plateau period. The point of the completion of learning curve, CLC, was calculated according to RC curve. It was considered completed after 30 cases. By the number of the 30 cases of CLC, we divided all the patients into 3 groups. There is significant difference between the periods before and after the CLC in operating time and the blood loss. And it is very interesting that conversion in group 1 was less in group 2. It's 1 and 5. We thought that we thought that the difference is because of the different indication criteria. In the early days of the training, only simple cases were selected for the candidates. Only when the technique matured, we performed the operation for all the patients admitted in our hospital without selection. But even when the learning curve has been completed, there is a lot to be improved. In our study, the difference of the operation time between group 2 and the group 3 is still evident. And furthermore, no. How to take back? And furthermore, we investigated all the factors to find out what were capable of influencing the length of the operation. We found that mom's age was the most influential factor. Exploring and understanding the factor of learning curve will guide the progress of surgical techniques. At the beginning of the training, younger patients less than 30 months age, 1 month after the remission of acute phase, complete relief of jaundice, no need of ductoplasty, and so on, are preferable. After CLC, the indication could be extended to all patients. In conclusion, the learning curve of laparoscopic choledochal cyst definite surgery presented the logarithmic recession correlation. It was considered completed after 30 cases. After 2 cycles of learning, the surgical technique is more preferential and steady, and the results are better. Thank you.
Question?
Thank you for showing nice data. I very much appreciate your good analysis in your experience. My question is, what is the reason for conversion? And again, I appreciate your honest data about the conversion ratio and the complication ratio.
Sorry, the reason of the referral?
Conversion from laparoscopy to open. What is the reason for conversion?
Laparoscopic to open.
Yes, I have shown the reasons of the the reversion. 3 were because of the severe adhesion, and the others were the other 3 were biolimp of low-Y twisted, common hepatic stenosis, and the other one is the accessory hepatic duct injury. Thank you.
Whit Holcomb from Kansas City. I want to congratulate Wynn on a very nice study. It's always important, I think, to look at your own results, and your results are very good. I had the opportunity of watching Wynn do this operation about a year ago, and it was about patient 75 or so, and it was a flawless operation, and I was thinking, I wonder what your learning curve was, and so I was really glad to see that at patient 75 or thereabouts, you were really a master surgeon in doing this operation, so congratulations.
Just one comment. I have one question. It's very interesting, this paper, because all procedure was performed by single surgeon. And between the first 23 cases to the second 23 cases, the operative time reduced 100 minutes less. So my question is, the surgeon used a model of training with the objectives to reduce a little bit more the learning curve.
How to reduce that?
You have in your hospital the model for the training?
I'm sorry. With the technical improvement, the learning curve has been, the time of the operation reduced sharply in the first period, and then it turned to the steady, I think.
Okay, thank you.
How many cases do you do per week, let's say?
Per week?
How many cases of laparoscopic choledochal cysts that you do per week?
per week.
Every week?
Every week.
How many cases do you do?
At the beginning, we have done the laparoscopic choledochal cyst excision for about 100 cases, and at the beginning of the operation, every year we only have about 10 a year, but many patients come to our hospital.
Okay.
So last year we have 60 cases.
Okay. Maybe this is why you have more cases, so the learning curve is improved.
Yeah.
Okay, thank you.
Thank you.